Greetings from Department of Oral Pathology, Yenepoya Dental College, Mangalore, and I am Dr. Vishnudas Prabhu, Professor, Department of Oral Pathology. This is an interesting case which came to our department. A lady came with a 13-month-old child which was female in gender and complained of a palatal swelling bilaterally. The mother had noticed that the child had scales on the scalp and consulted a dermatologist. After 2 to 3 weeks, they noticed that the child was crying, holding the ears, and they visited an ENT surgeon. After a few days, they again visited a pediatrician who prescribed antibiotics. The past medical and dental history were not relevant, and the child was moderately nourished and the vitals were normal. This is the intraoral picture of the swelling. A blood investigation was performed. The hemoglobin was seen to be decreased, and the complete urine and liver functional tests were performed as normal, and creatinine and C reactive protein levels were also normal. Radiographically, there was a large radiolucency with partially developed deciduous teeth leading to a floating appearance. A provisional diagnosis of localized chronic periodontitis was given, and a differential diagnosis of cyclic neutropenia, Langerhans histiocytosis, and Papillon-Lefer syndrome was given. The mother was demonstrated to clean the oral cavity with gauze and chlorhexidine mouth rinse. Once the oral hygiene improved, extraction of the deciduous molars were carried out along with incisional biopsy for histopathological examination. Histopathologically, we found an ulcerated parakeratinized stratified squamous epithelium and sheets of proliferating mononuclear histiocytes intermixed with a dense inflammatory infiltrate. Some histiocytes showed cleaved nuclei or nuclear grooves. Large areas of necrosis admixed with neutrophils, lymphocytes, plasma cells, and few bacterial colonies were also seen. Immunohistochemistry was performed, and CD1A marker was strongly expressed. It led us to a diagnosis of Langerhans histiocytosis. PET scan was done, which confirmed again the multisystem involvement of Langerhans histiocytosis. The patient was referred to hemo-oncologist for further management, and now the patient is undergoing chemotherapy. The patient is under regular follow-up and no recurrence is noted till date. Initially, Langerhans histiocytosis was proposed by Lichtenstein's in the year 1953 as histiocytosis X. Earlier, the term Langerhans histiocytosis collectively comprised of 3 various clinicopathological disorders such as eosinophilic granuloma, Hans-Köller-Christian disease, and Letterer-Sieve disease. It is characterized by abnormal proliferation of histiocytes. It belongs to dendritic cell disease and is most commonly seen in children. Oral manifestations are the earliest to be seen in about 5 to 75% of the children, and in oral cavity, maxilla and mandible are more commonly affected in the ratio of 1:2. Radiographically, we can expect to see localized punched out radiolucences leading to a floating tooth appearance. Histopathologically, we see cluster of cells with reniform nucleus that are glued deeply like a coffee bean. Special stains with metal impregnation staining techniques using heavy metal such as gold chloride, osmium iodide, and ural acetate lead staining is also performed. The markers for immunohistochemistry are CD1A, S100 protein, and Langerin. The treatment for Langerhans histiocytosis is surgical excision, chemotherapy, and radiotherapy. Conclusion: early diagnosis of Langerhans histiocytosis plays a very pivotal role in the prognosis of the disease. Awareness of oral symptoms of Langerhans histiocytosis may aid clinicians greatly in reducing morbidity and mortality associated with this debilitating condition. Early diagnosis and effective treatment of Langerhans histiocytosis have been documented to not only prevent the progression of the disease but also to avoid further complications. These are the literature which I referred, and thank you very much.